Good morning, all.
Morning.
So glad to see so many of you here. We are being live streamed, and we have a wonderful program, very informative program for you. But first, just a few words. If you have not signed in at the door, please do so, so we'll know who and how many came this morning. I also wanted to mention that at our April meeting, Dr. Marian Johnson talked with us about Medicare, and she got a lot of questions afterwards. So she and Jim Farrenholt put together a handout on Medicare and for some of your answers. So please, if you haven't picked it up, make sure you get that Medicare handout. Very informative. There's also a handout. It's a summary of our state membership meeting that was held on April the 29th. The meeting highlighted the shortage now and in the near future of medical personnel all across the Commonwealth. That's got good information too, so you better make sure you get that. A question came up recently about renewing membership. Some people apparently thought they didn't need to pay a fee again, but you do. The fee is renewing your membership in the Cedarfield VACCRA, the state VACCRA, and the national VACCRA. It is a yearly fee. Now I understand, and I'll check this out to make sure I'm right. If you renew online, it's $10 cheaper. Is that right, Sally? That's what it says in the brochure. There will be no meeting of membership in July and August, but that doesn't mean we're not going to be working. We will be naming a nominating committee to present a slate of officers, and we have developed the Cedarfield VACCRA bylaws. Both of these things will be voted on in the fall when we return. Okay. If you know somebody, by the way, we have 115 members, which I think is pretty great. Great. Now, I'm sure many of you probably know someone who is not a member. It would be very helpful if you talk to your friend or your neighbor, explain to them who we are, what we are about, and encourage them to join. Don't forget, we're an advocacy organization. We are an educational organization. We are not adversarial. So please encourage our membership to grow. We all know there is strength in numbers. We are so very pleased to have Eleanor Jones and Debbie Griffith with us this morning. Eleanor is from Honoring Choices. Debbie is employed by Henrico Doctors Hospital, right? Henrico Doctors. They are both heavily involved in what they're going to present to you today. It's good information, and I must give credit where credit is due. I would never have heard of Honoring Choices had it not been for Mary Ann Johnson. We talked for an hour one night on the phone about that. Got very interested in it, and we all thought this would be something Cedarfield residents should hear about. So it is my pleasure to present Eleanor Jones and Debbie Griffith, who's going to talk with us about Honoring Choices and answer your questions.
Good morning, everybody. Thank you. I'm Eleanor Jones. We are very excited to be with you today. I'm used to wandering around. It's hard to stay in one place, but if you can't hear us, just let us know. I'll just tell you really quickly about Honoring Choices Virginia. We are a 501c3 nonprofit devoted to promoting and advancing access and equity to advanced care planning, which many of you probably have already heard of advanced directives, or you've had healthcare professionals ask you about it. And advanced directives are one very important piece of the work we do in advanced care planning, but we always like to say it's really about the conversation. We were founded in 2014 with the Richmond Academy of Medicine, who we still have a wonderful, strong relationship, but I know we have some RAM physician members present, so thank you for your involvement there. And we also were founded by the 3 local health systems, so Bon Secours, HCA, and VCU Health. And we were actually the first, and to our knowledge, only time all 3 health systems came together to start an initiative because all 3 health systems just knew how important it was. We still work within the health systems to different degrees. HCA, Henrico Doctors Hospital, have been our closest partner. And like I said, we still work within the Richmond Academy of Medicine. We do work with health systems all over the state. We do advanced care planning training for professionals across the country. We've worked in Johns Hopkins University doing training as well. So we're a small but growing organization. And at this point, I will turn it over to Debbie, who will also introduce herself.
Good morning, everyone. And as Eleanor mentioned, I too like to roam, and I get very animated. This topic is so important. Little background, I'm a registered nurse. My background is intensive care nursing, and it probably has been about almost 30 years that I've done intensive care nursing. So I'm coming from this as a provider of providing care to patients. And what I found over the years is that very often, you can't really make a good decision unless you have good information. And so I'm all about talking to people about information, what their options are, and then including into that quality of life. And quality of life is very different for all of us. Currently, I've transitioned from an intensive care unit nurse, and I think I'm probably the only full-time advanced care planning facilitator in any hospital in Virginia. So this is all that I do all day long, is talk with patients and families about what their wishes are for future medical care, because unless we have that conversation, we don't know how to provide the care that you or your loved ones would want, and that is so important. And actually, the hospital has just agreed to hire an additional person because they do find that this is such an important topic, and it really is about quality and making sure that we're providing the care that everybody wants. Before I get started into the presentation, I'd like Mary Ann Johnson to come up and just give a couple minutes of background as far as how she got involved in it and how we connected, aside from her husband being my OB.
Bruce and I both had Honoring Choices as our advanced directive. We got involved in 2014 when it was new at the Richmond Academy. We were there at one of the first formation meetings that we had on a Sunday afternoon. And everybody goes to their lawyer and everybody in their will puts down a DNR. But this is much more than that. And everybody makes mistakes when I think what they're getting into, even I, who filled out the first form, and Debbie said, I don't think that's really what you want to do. So we walked through it to put down what was reasonable for me. It gives you choices, and the example might be my husband. he had filled one out, and we had, different things like, if they really think I'm going to be okay, do everything. If it looks hopeless, do nothing. And if it's somewhere in between, let's weigh the odds and use the medical judgment of how I'm going to come out of this unscathed. He was diagnosed March 31st with stage 4 pancreatic cancer, and we were going to try an attempt at chemotherapy. And he got really dehydrated, and we walked into Henrico Doctors, and he needed to be admitted. His blood pressure was really low. He'd been throwing up, the whole 9 yards. And the first thing the ER doctor says, "Do you have an advanced directive?" And I said, "Yes." And she said, "Well, then we're doing nothing." And I said, "No, that's not what our advanced directive says. He has not made that decision yet." And we called Debbie, who then interceded for us through the whole process. So he went in, and with the attempts that we were going to hydrate and maybe make it through chemotherapy to see if maybe he could get a couple extra months. And it became totally obvious after 4 or 5 days that we were going nowhere with this, and he was miserable. And at that point he said, "I cannot do that." And there was Debbie to walk us through getting into hospice, getting everything home, what to expect and how to do. So going from walking in the hospital dehydrated, thinking maybe we have a chance, and somebody just saying, "Well, we're not going to do anything for you," to actually making it through 4 or 5 days and then trying to figure out what was going to be right with us with somebody walking right by our side was very comforting and a good thing to do. So DNRs tend to be a little black and white, and I always say this kind of puts the gray in it. So you do have a choice, and everything isn't just black and white.
Thank you. Thank you for sharing. I'm tearing up now. Sorry. As you can see, these conversations are very personal to me because I really think that we do help a lot of people. So how many in here, raise their hands real quickly, have an advanced directive? Okay. How many have had a really good conversation with the person that's going to be making your medical decisions for you if you can't? Okay. So having that conversation is very important. So as I mentioned, I'm an advanced care planning facilitator. So it's not so totally about the document. It's not totally about the advanced directive. It's about the process. The process really should start for anybody that's 18 and older. This is not a document nor a conversation for those of us in our later years or with chronic health conditions. Everybody should have a basic conversation about what their wishes would be in the event that something happens to them. And that's from 18 and on up. As we go through life, as we get older, and as things start happening, as life starts happening, you should continue to have these conversations, look at your document, and adjust your document to what your current wishes are. It's evolving. Okay, so it's not a one and done. It's kind of like if you're looking at your insurance or your car insurance or medical insurance or whatever. You're constantly looking at that to make sure that it's meeting your needs, right? Same thing with this conversation in the document. So advanced directives are normally filled out in conjunction with someone's will or durable power of attorney, which is more financial. But an advanced directive, often when you're having a conversation with an attorney, you're not really including your medical condition and your life experiences in that conversation. The document is very black and white, and there's a lot of gray areas in there. So, and I view the document more about how you want to live, but then also thinking about when the time comes, how do you want to die? I was at a seminar when I was first learning this process. There was probably about 200 nurses and other medical staff in the room. And the presenter had asked us all to shut our eyes, and then she asked us to think about when we die, where do we want to die and how do we want to die? And then she said, now keep your eyes shut and then raise your hand if you want to die in the hospital. And out of that entire room, only 2 people raised their hand and said that they wanted to die in the hospital. But nowadays, how many people actually do pass away in the hospital versus at home? And so, you're really not having your wish as far as what your care is. So advanced care planning is that process. The process should accumulate in a document called an advance directive. An advance directive does a couple things. Sometimes when you go to an attorney, they'll divide up the advance directive into several different portions. The one item is, as long as you have capacity, as long as you are in full command of your faculties and can make decisions, whether or not your family or loved ones agree with them or not, you are in full control of every step of your medical decision-making process. In the advance directive, though, if you lose that ability, either for a short-term period of time or for permanent, meaning you lose the capacity to make decisions, then those decision makers go to, if you've completed an advance directive, it goes to the people listed in your advance directive. We prefer to call them a healthcare agent. Often the terms are called medical power of attorney. Very often, though, what we find is that the medical power of attorney people confuse with the financial power of attorney. And when you're looking at a durable power of attorney, that usually has to do with finances and contractual items. It very, very rarely has to do with any kind of medical decision making. There's usually like one small little paragraph or 2 sentences that would allude to that person having the ability also to make medical decisions, but very often it does not. So whenever a person comes in and says, oh yeah, I have documents, this is my power of attorney, I always ask, do you have an advance directive? And I also clarify, is this person just a financial decision maker, medical decision maker, or both? So it's very important to understand that there is a difference. So that's why we try to refer to that person as a healthcare agent, because they're really, working in regards to your healthcare decisions. So we have a primary healthcare agent and then a backup in case that primary healthcare agent can't be reached, or if they, for some reason, decide to decline in wanting to be able to make those decisions. If you do not have a document, then it goes according to Virginia hierarchy. So I noticed that not everybody in here had their hands raised when I asked if they had a document. So in Virginia, we have a legal hierarchy that the state has established. So if you do not have a document, it is your court-appointed guardian, if you have one. And then it goes down to whoever it is in your advance directive. And then thereafter, it's your legal spouse. Sometimes we have people who have been separated for 20 and 30 years, but they've never gone through any divorce proceedings. Guess who is the medical decision maker? So, and believe me, I have seen it all. And then it goes down to your adult children, and we always have to take into consideration whether they're legally your children or not. Some people refer to their stepchildren as their stepchildren, but then I always have to ask, did you adopt them? Because if you did not adopt them, they are not legally your children. So there's a whole bunch of different caveats in who is your medical decision maker. Some people have one child, some people have 13. Trying to get 13 people all on the same path and thinking the same way can sometimes be very difficult. So I'm going to stop right there, and I want this to be interactive. I don't want to just stand up here. Does anybody have any questions about medical decision makers? Real quick. Yes, ma'am.
Is a living will the same thing as a medical directive?
It is. So the living will has to do with so the question was, is a living will, thank you for reminding me. So the question was, is a living will the same as a medical directive? So there are three components to an advance directive. One is who is your medical decision maker? The second component has to do with your medical wishes, which then would be that part of that would be quote unquote your living will. And then the third part has to do with organ donation. So if you do have a living will, then you probably also need to have a separate document that identifies who your medical decision makers are. Good question. Any other questions? Yes, ma'am.
I may be skipping ahead. I know when my parents were at Lakewood, they were supplied by Lakewood or someone with a sample.
Sure.
And it was good, excellent. And in the hospital, I was told by the nurse it was one of the best they'd ever seen. Do y'all have that, something that you give out?
Sure. So the question had to do about types of advanced directives. There's a lot of advanced directives out there. We use, through Honoring Choices Virginia, we use the Virginia Hospital Association Advanced Directive. There's other documents out there, 5 Wishes and Jehovah's Witnesses have a document that, is very short. So there's multiple documents out there. The other thing too is you can take a paper towel. You can write the date down, you can write your wishes down, as long as it's signed, dated, and witnessed by 2 people over the age of 18, that is a legal document. So, does that answer your question?
Do you supply these forms?
We have the forms, yes.
How do you like?
So we'll have Eleanor link up with you all to get you some forms. But again, going back to Marianne Johnson, just remember, you fill out a form. Sometimes you're not really looking at the form the way it needs to be looked at. So it's really making sure that it's the conversation that you're having and not just filling out a piece of paper. Yes, ma'am.
I don't know if y'all know, they're set up so you can make appointments and meet with someone, and you might mention that, and go over this and have this discussion. And if you need to, you can go back and forth. You can bring your children. You can bring whoever your medical director is if you want to. I don't know if you're getting to that.
Yes. Sure.
This is a great question. Thank you, and thank you for mentioning that. One of the largest pieces of work that we do is actually connect individuals to conversation facilitators. A large part of our work is actually legally training certified facilitators through the Virginia Department of Health to be able to legally help people complete the document. And like Debbie said, it's, there's all the basic questions, what do you want? But then there's all that gray area of what does it actually mean? Or to Dr. Johnson's point, do you know your rights? Do you know what this document can do for you? Because the other half of our work is also training medical professionals to make sure they understand the document and how it can work for their patients. Because there's, as of right now, no formal required training in that area. And so we love working with our physician and our nursing partners, our PAs, social workers, all sorts of folks. So we usually do it at the end. I'll mention it again later, but I'll invite each of you now to actually make an appointment with us and have a facilitated conversation where we talk about all these things Debbie mentioned, prior experiences, fears or concerns, what the document can do, what it can't do, other documents you might want to pursue, and I know Debbie's going to talk about DNRs and DDNRs, etc. The other thing I'll just mention really quick before I turn it back over to Debbie is most of you, I think, picked up this booklet here. This is a resource we made. We made it with our physician and nurse partners in our health systems alongside many community partners and other nonprofits and faith communities. This really takes you through the conversation. So, starting at the beginning of just what is this and who is it important for, what Debbie was first talking about, any fears or concerns. Dementia runs in my family, it's a fear of mine, or, I don't want CPR, or I don't really understand intubation. Can you tell me more about this? I don't know if I want it or not. It goes into exploring past experiences. It goes into exploring beliefs, right? Like I want last rites, or don't bring a chaplain to my room, or anything like that. It goes into exploring goals of care, and that's the living will piece. And it gives you a scale here to look at personal preference, which is different for everybody. And then one of the last pieces too, this also talks about, gives some definitions of interventions, like what is persistent vegetative state versus coma. There's a slight difference. Talks about organ and body donation, and then some other questions. And then what to do after you make your document, right? Because if it's in a lockbox that nobody can get at, it's not going to serve anybody very well. So this is very much when you schedule a conversation with us, when you go to Debbie or someone like her, this is sort of the pattern that the conversation will follow. So thanks for letting me judge it.
You're welcome. As we mentioned, there's many different types of plans. The 5 Wishes, Jehovah's Witness, the medical directive, or just writing your own. At any point, once you fill out the document, you can change the document, revoke it, by just writing revoke on it with a date and letting your family or your healthcare agents know that you've revoked the document. Or when we complete a document with honoring choices, we have a face sheet that we put on the front of it. And included in that face sheet is a list of people that you are giving a copy of that document to, so that when you go to change your document down the road, then you would know to go to these people or these your provider or your healthcare facility to let them know that you have a new document and to give them that document. There are, we call it the 6, I used to say 5 Ds, but there's actually 6 now that we've come up with. So anytime that you should re-look at your document is anytime you have a divorce or do-over, you should look at your document. Because if you have your ex-spouse or whomever on your document and you're getting divorced, you might want to look at getting that document changed. My daughter, the day she came back to our house after she separated from her husband, I had the document sitting right there on the coffee table. And I said, Tracy, before you go any further, you're going to change this document and you're going to put somebody else down as your medical decision maker. She didn't have a document to begin with, but she hadn't initiated divorce proceedings. So the only problem was she got remarried and she still hasn't redone the document. So guess who's her medical decision maker? Which is fine with me, you know. So divorce or do-over. Death of a loved one. So, you know, think about it. If a loved one of yours passes away and they're listed in your document, you might want to change that. Anytime there is a new disease diagnosis, okay, so if you get, you go to the doctor and they diagnose you with something, you may want to have a conversation and relook at your document. Anytime there's a decline of your current disease state, some, diabetes, Parkinson's, Alzheimer's, COPD, these are all congestive heart failure. These are all progressive diseases that don't get better in the long run, and you're going to see a slow decline. I mean, there's others also, but you always want to relook at it every decade, and I'm missing one. Anytime you move. So especially if you're moving from state to state, as long as that out-of-state document has been completed legally, we still honor it, but it's also something that you should look at when you do move. and people's addresses and phone numbers change and things like that. So, just real quickly, just a couple minutes. For those of you who have completed a document or maybe who have not completed a document, can I just get some idea about what some fears and concerns that you might have about doing the document or invoking, having the document in place? Anybody? Yes, ma'am.
Someone is mentioned in my documents who has moved out of state. Does that make a difference?
So the question was, if someone was in her document and they moved out of state, does that make a difference? No, it does not. So as long as that person can be reasonably reached and we can get a hold of them, via phone or whatnot, that person is perfectly appropriate to be your medical decision maker. Yes, ma'am.
When you're in that particular situation where you need the directive, who does the calling of the person? Like if you're in the hospital, if you're here in healthcare, who makes that phone call?
Sure. At the hospital, it would be the provider, or if I'm involved in the case, I'll start calling and having the conversation with the healthcare agents.
But you're only at Henrico Doctor.
Yes, ma'am.
So, if I'm at St. Mary's, that's not going to help me, right?
Nope.
So it would be whatever hospitalist is in charge of my care.
Correct. And, very often what we find too is that when you come in through admissions, they ask you to put down person to notify or next of kin. Very often, it's not the legal medical decision maker. So make sure that if you are, being admitted to the hospital, that you're putting down your legal medical decision maker. Sometimes people put their, next door neighbor, their friend, their pastor, whomever, but it doesn't help us if you're unable to make medical decisions and we're calling the person and they don't have a document that gives them authority, but yet, you may have a daughter up in New York that we don't even know their name and how to get in touch with them. Yes, ma'am.
Are most Richmond hospitals associated with honoring choices like Bon Secours?
So the question is, are most Richmond hospitals associated with honoring choices like Bon Secours? So we are, but we have a big problem. We don't do a very good job of, number one, obtaining copies of your documents. So think about it. If you go to an attorney, what does the attorney do with those documents? He gives them to you, and then what do you do with them? Some people will take them to the safe deposit box at the bank and stick them there. Well, what good is that going to do if the bank's closed and we don't have the document and we don't have the key or the access because now you're in the hospital and you don't have capacity? So you need to share your documents. You need to, every time you go to the hospital, bring a copy of the document. The other problem that we have is that hospitals don't share documents well. They don't. So if you're a patient that historically goes to a Bon Secours or Mercy Hospital, you may have your document there, but then if you end up at Henrico or VCU because of diversion, we're not going to have access to your document. Now, we have come up with some workarounds. Again, I'm the only full-time advanced care planning facilitator at any of the hospitals, so I will contact some of my cohorts in crime at the other facilities that I know and say, so-and-so said that they've been a patient at your facility. Do you have a document? And they'll look and they'll send it to me. So we kind of do the backdoor thing. But then also your family members all should have copies of your document. And then there also is a state registry. But the problem with that is you actually have to sign up for that registry, and then you have to upload your document. And I don't know about you, but I am not computer literate. It's difficult for me to do some of these things, you know, copy things and upload and scan and all that other kind of stuff. So, you know, we just don't do a very good job. It would be wonderful if the state would do the same thing that they've done with medications, where, you know, all of your medications, no matter where you are in a facility, they can, you know, get that information through your pharmacies and things like that. So that would be my ultimate goal down the road, is seeing if we could get some legislators to start working on that. So good opportunity for your program also. So
I'll just need to, if they need help, they can contact.
yeah, and if you need any help sharing documents, you know, contact Honor Choices, Eleanor. Yes, ma'am, in the back.
I am a little confused as to where hospice comes in with this.
Okay, the question was that she would like some more information about hospice, and I'll get to that. And I will get to that. So just really quickly, as far as fears and concerns, people think that, you know, their healthcare agents are going to take over their care. Again, as long as you're in full control, there's no way that your healthcare agent can say, well, I don't want mom to get upset, don't tell her. Or, you know, I'm making the decisions because I'm her medical decision maker. Well, no, I'm sorry, I respect that, but as long as mom or dad have the capacity, they are in full control of their medical decisions, and I will be an advocate at any point in the road to make sure that you are in full control. People also fear that, some people fear that if they write it down, it's going to happen. I mean, seriously, I mean, some people do. So, you know, those are just some concerns that I have come across. So thinking about who would be your healthcare agent. Most people put their significant other or their children down, but sometimes that may not be always the best choice. What we suggest is, number one, is that person willing to be your healthcare agent? Second, does that person know what's going on with your medical condition? Third, is that person willing to honor what your wishes are, even though they don't agree with them? It's very hard, you know, for some people to be making these decisions. And then fourth, does that person react well under stress? I was doing a conversation with one of our employees at the hospital. His father is a doctor, and he's married. And he did not want his wife to be the medical decision maker because he said, my wife can't even walk into a hospital. If I'm sick, she's not going to be able to walk in and see me and participate in the care. So I don't want her to be my medical decision maker. So think about those, you know, qualities in who you are picking as your healthcare agent. And again, you know, some people want their coworker to be their medical decision maker. A lot of us nurses pick our coworkers because, you know, they know what we want. But it's also very, very hard on families because you have those heartstrings, you know, and I totally understand that. So we will continue to get in touch with your healthcare agent. If we can't reach your healthcare agent, we will go to the backup healthcare agent. I don't know how many hours I have spent on Facebook Googling obituaries of various patients' relatives to try and find next of kin. I have, you know, so, I mean, we try very, very hard to find next of kin and decision makers, and sometimes we don't. If we don't find someone that is a medical decision maker that is within the legal medical decision hierarchy, then we have to speak with the local judge and get a court-appointed guardian for that patient if they're unable to make medical decision-making. So it's a very in-depth process. So again, you know, if you need any help with who would be a good agent for you, then, you know, we're more than happy to help out. The other thing is, when we're having these conversations, we really encourage your family to be part of the conversation, even if they can't be there physically, at least participate on the phone, because it's very helpful for your family or your healthcare agents to hear what the responses are to some of the questions that we have. So for example, you know, some of my questions are, tell me what you understand about your congestive heart failure. Tell me what you understand about your COPD. Tell me what the doctors have been talking to you about as far as long-term treatment and prognosis. Tell me what living well means to you. What gives your life pleasure? Because when you get to the point where you're not living well anymore and you're not having an acceptable quality of life, your wishes may be different at that point in time. Tell me how you deal with challenges. What helps you? Is it religious? Is it family? Is it yoga? You know, what helps you get over a dark period in your life? And then we start talking about wishes for future medical care. In an advanced directive, like I said, in that living will section, there's really only two things that are talked about. One is when the person is in a, and I hate this word, a persistent vegetative state, or they're a vegetable. There's many different types of states that you can be in, but it really comes down to, again, quality of life and what is acceptable to you. Think about, if you could not do X, Y, and Z, what would your wishes be at that point? And that's what it's really all about, okay? So it talks about persistent vegetative state, and in the document that we use, it basically says something to the effect of, you're laying in the bed, we're providing all the care needed to keep you alive, you're unable to open your eyes, you're unable to recognize family, you're unable to interact meaningfully, and the doctors are telling your loved ones that there's little chance that you will ever recover those abilities. What would that mean to you? We don't ask, what do you want us to do? We ask, what would that mean to you? And then we have that conversation about what it would mean to you. And then from that point on, then we start talking about what your wishes would be. We never stop treating a patient, whether we're treating someone aggressively to try and cure them, or palliative care is more about symptom management. My husband has multiple myeloma. He is not curable, so therefore any care he gets is palliative care. It's treating the symptoms, trying to help him feel better. It's not a curable disease. He's been ill for 8 years, okay? And we know he's a palliative care patient, but he still wants all care needed to keep him alive. So palliative care is more treating symptoms, and you can have palliative care while you're still seeking aggressive therapy, or the other option, to your point, ma'am, in the back, is hospice care. Hospice care is really more about transitioning care from aggressive therapy to focusing on comfort, to focusing on providing one the best quality of life in the time that they have left. And that's what hospice care is all about. So I'm going to skip over some of this stuff because I think some of the other things from a nursing standpoint might help you guys. So hospice care can be given in 3 locations. Hospice care was originally designed for treating and caring for someone at home by the family with their loved ones present. Sometimes that's not always the option. Every insurance picks up hospice care, so especially if it's at home. They provide, there's multiple companies out there, and they all provide the same type service. They provide a team that will oversee the care. They will provide medications. They will provide almost all the equipment that someone would need, including a hospital type bed, oxygen therapy, bathing supplies, medications, things like that. Some people think that hospice care means that you're not going to be taking any medications. That's not true. You still would continue certain medications in hospice care. You can revoke hospice care at any point in time. Hospice care, we do every so often have people that graduate from hospice care and don't need it any longer. I can't see that far back, and you have the sun behind you. I think she's giving me a time frame. So that's hospice care at home. The other option is in a nursing home or skilled facility. Again, you have to kind of look at how, paying, and insurance will pay for the hospice care in a skilled facility, and then sometimes people have alternate or out-of-pocket funds to pay for the room and board. And then every so often people are so symptomatic that they need hospice care in the hospital. That's called general inpatient, and those guidelines are really set up by CMS, Medicare, Medicaid, as far as what symptoms and what type patients could get hospice care in a hospital. It's really for those patients that really need a lot of work with medications to keep symptoms under control, agitation, pain, shortness of breath, things like that. So inpatient hospice care is not always available. There are some companies that do home health, palliative, and hospice care. There are some companies that just do home health palliative, and then some companies that do palliative hospice, and then some that just do hospice. So there's a whole big smorgasbord out there. So I'm going to stop right there and ask questions about what I just talked about hospice care. Yes, ma'am.
A question that I have is, how do you recommend dealing with a place like this when it comes to DNRs?
Okay.
I can go and get an ACD, but I don't know if that person is a DNR.
Sure. So, and thank you, and that was something that I had asked a couple of the ladies to remind me about it, towards the end of my conversation. So, I'm going to ask a question. For those of you that have an advance directive, is that a do not resuscitate? Raise your hand if you think that's a do not resuscitate. It is not. An advance directive, although in your advance directive it talks about the vegetative state or imminent death, what you're putting in there about if you are in a persistent vegetative state or you have an imminent death or terminal illness or whatever that you're not going to recover from, very often it says, I do not want artificial nutrition. I don't want IV fluids. I don't want dialysis. I don't want CPR. I don't want a breathing machine. But number one, that's not a doctor's order. It's only your wishes. And those I don't wants only pertain to those 2 conditions. A terminal illness with no chance of improvement or recovery, or a vegetative state. It does not talk about some of these other situations where maybe you're not truly terminal, and you're not really in a vegetative state, but you just, if your heart stops and your breathing stops, you want a natural death allowed. The alternative to natural death is CPR. So CPR is cardiopulmonary resuscitation. CPR only goes into effect or is considered when you have died. Your heart stops, your breathing stops, you are dead. Do you want a natural death at that point, or do you want us to attempt CPR? So a DNR is a do not resuscitate, and that is something that is a in-facility or in-hospital doctor's order. You can have your advanced directive sitting on your chest when your family members call EMS. But if EMS is called and they do not have a doctor's order, they are going to perform CPR. So, DNR is a doctor's order. Once you leave the hospital, you have a DNR. If you want that to continue, you need to get a physician order filled out. It's called a durable do not resuscitate order. And that order needs to be signed by you and a provider, and that order cannot be revoked by anyone except you or the provider that signed that document. So if you lose capacity, your healthcare agent cannot revoke that document. People in this type of a community, you're getting out. You're going into various, rooms like here. I don't know who has a do not resuscitate. Virginia Department of Health, and I can help you with this, or Eleanor can, has approved 2 businesses that you can obtain a do not resuscitate necklace or bracelet. They do need to have a copy of your do not resuscitate order before they will even fill it out for you. It's about $30 or so with shipping and handling, and that necklace or bracelet is as valid as having the doctor's paper with you at the time. Okay? So if you go out into the community, or if somebody was to drop right here, we have to resuscitate you because we don't know. Does that answer your question?
So it's incumbent upon the individual to take the responsibility if they want to be truly a DNR, to have the paperwork and a bracelet or...
Yes, ma'am. And you can't go to like one of those pharmacies and, where they engrave your medical, history and stuff like that. That's not a valid, legal, do not resuscitate necklace or bracelet. There's also another doctor's order form out there, and that's called post-physician order for scope of treatment, and I think that's what we actually filled out for Marianne's husband, and that actually includes not only his wishes for when, his heart stopped, but it also incorporated wishes for future medical care, and in some situations that would include, I want to be kept comfortable, I don't want to come back to the hospital, or I don't want to have a breathing tube put down my throat, I'm okay with oxygen and other support, and then it also talks about feeding tubes and artificial nutrition. Yes?
I don't know if anybody knows this, after the chef, I don't know who was here, when the chef had his massive heart attack and somebody from the kitchen did CPR and he went her to the hospital. The question came up, and I talked to Buzzy May about this, about they're not readily available AEDs. And I was told that and I asked why some of the wait staff or the hostesses might not be trained in just plain builder basic CPR. And this is stuff that's all in the community. And I was told that by Pinnacle, and I will verify this again, that they didn't want them trained because institutions have been sued by people that really had a DNR, and they then were resuscitated, and so they didn't want this out there. So I think anybody that really does have a true DNR, this includes healthcare too, needs to have the bracelet or the necklace, because I know for me, if I had my massive heart attack up in the dining room, I would not like them to walk away and say, oh, she's a seated for a bracelet, she has a DNR somewhere, goodbye. Because that's not what I would want to do. So anybody that really has a DNR or has a family that really feels struggling, I think they need to have the bracelet or the necklace, and then maybe we can get some more AEDs and some stuff around so they will not be afraid of a suit.
So I'm going to talk real quickly about CPR. Everybody sees CPR on the TV. CPR on the TV has about a 70 to 75% success rate, right? You see people getting CPR and then, you know, they're walking in the hallways within an hour of, you know, being dead. So CPR, it's when your heart stops, your breathing stops. You are not getting oxygenated blood to any part of your body. Your brain is very sensitive to no oxygen to the brain. When you have lack of oxygen to the brain, it kills brain cells. Those brain cells do not come back once they start getting oxygen. So we never know, you know, how much damage has been done. So what we try and do is we try and get oxygenated blood circulating. We do that by chest compressions. We do that by breathing for someone, and in the hospital or EMS, they'll put a breathing tube down someone's throat and we'll breathe for them. We give medications, and then if need be, if the heart is in an irregular rhythm that is lethal and it's a shockable rhythm, then we can apply external electrical activity to one's chest to try and stun that heart and try and get it back into a regular rhythm. Some of the complications that occur with CPR is when we're doing the chest compressions, we break ribs. Those ribs can puncture a hole in your lung. And then also when we're doing CPR, we're not as effective as the human body in getting that oxygen to the brain. And so you still sometimes have lack of oxygen going to the brain. When I ask people about CPR, they say they want to live. Tell me what living well means to you. And then we talk about success and outcomes. Give me some ideas about how successful you think CPR is.
I just know in a personal situation with a grandmother, it was never honored. And she finally asked me to plaster copies of it on her wall. And then at 100 years old, she was asking the nurse, what do you not understand about a DNR? So it's hard to get people to...
It's hard because people, unless they have a very good conversation, they don't understand. So healthy people that have CPR, they have about a 20 to 25% chance of leaving the hospital alive with or without brain damage. People who have chronic health conditions, especially chronic health conditions that can't be fixed, people who are older or weaker, it's about 2% chance of leaving the hospital alive with or without some brain damage. And it's everybody's individual decision. If someone wants CPR, that is perfectly fine. That is perfectly fine. But as long as you understand, you know, how this could potentially affect your life down the road, and is that 2% or 20 to 25%, is that an acceptable quality of life for you? It's really about each individual person. And I've been given the signs that I'm done. So, any questions real quickly, and then if not, I'll stick around, and if anybody has any specific questions, I'd be happy to help. Yes, ma'am, in the back.
This is going to be a quick one because you never addressed, if you're in a vegetative state and they're giving you palliative care, how can you, there is a way to, in other words, I want to die. I want the choice to die. Can you do that?
Yes, ma'am, and that is through a conversation with your provider or having a conversation with one of us. We can complete a post form. And very often if you're receiving palliative care, very often they are there to help you with the next steps. But it's really about having that conversation and you expressing your wishes, either if you can in person, or your family being your advocates, or your healthcare agent being your advocates.
And if my advocate says my mom wants to go, they listen to her.
They should. Yep. And if not, I'd like to know why.
About the film. Family picnic.
Oh, so,
It's family.
right, and Eleanor will have this available also. There is actually a Respecting Choices, when Respecting Choices first kind of came out, it came out of a, what's the town in Wisconsin? La Crosse, Wisconsin. And so this whole town pushed these conversations. And Brian Jennings, is that who it was? Yeah. He kind of was the, he talked people through the whole program that they had in La Crosse. And so we'll also provide you guys with the link to see that movie. It's about a gentleman who had lung cancer and his journey through these conversations. Anything else? Any other questions? I hope this has helped. Thank you all.
I've already asked them ask if they could come back in several months or maybe another year. We get new people all the time. Situations change. We might need to hear more information. What do you think? Yeah, I think so too. Yeah. Before we adjourn, did the members get the Lifeline, the newsletter from the National? Yeah, some people are saying yes and some people are saying no. It came yesterday. Every member should have it. It's taught, and you need to read this. The future of CCRCs, skilled nursing services, particularly interesting. When you get it, please read it. I think Eleanor and Debbie might stick around for a few minutes if anybody has individual questions, and if anyone wants to make appointments. They're ready to take appointment times if you'd like to have this very important discussion with them. Thank you for coming. We'll see you next time.